Okay, no singing required. I will promise to speak slowly, and if I speak too fast, please don't be afraid to go to this like that to me. So welcome everybody. This is a momentous occasion for EFCCA in relation to their cooperation and relationship with ECCO. So we welcome everybody to the EFCCA conference on IBD Dialogues, Building Generations. We have a packed agenda to get through, so bear with us. We will look at timings in relation to questions after each speaker, but we also have a panel discussion at the end, so we can also ask questions at that point. So I'm delighted to welcome our President, Salva Leone, who will open the conference.
Good morning, everyone. I'm very happy to welcome you to this event. Kira just announced the title, IBD Building Generation. I mean, the theme of the day has two keywords inside. Is the generation and the dialogue. Dialogue between stakeholders. The theme of the day is important because lately we talk about patient need, what the patient needs in order to have a better quality of cure and quality of life. And I do believe that we have to focus on this new approach, that the patient needs are related to the gravity of the disease, the situation, the activity of the disease where the patient is at that moment, and finally of the age, because the patient needs are different if they are youngster, if they are adult patient, and if they are older. Today we will see how also ECCO is dealing with the elder patients, but the real purpose of this meeting is to foster a collaborative environment between healthcare providers and also patient community. Because we need to work for an innovative solution for the patient community that we represent. It's important, the synergy, because we need to understand how the scientific society work, the doctors work, and the doctors need to understand better what are the patient needs, because it's clear that sometimes when the patient goes to a visit, don't tell everything to the doctor, because there is a lack of time, because sometimes he doesn't feel, accepted at the doctor, but maybe the reason could be very different. So today, as Kira mentioned, it's a very historical moment for us, because I'm very happy to show that for the first time in the EFCCA history, this meeting was included in the scientific program of ECCO. So for the first time, the patient community is inserted in the program, and I hope this will be the first time of many times in the future. So I have to thank to do different thanks before giving the floor to Britta. The first is to delegate that supported the survey that today we are going to present for the insight they gave us. The Leiden University Medical College for the support in creating this survey and also for analyzing the data. A special thank to Britta, the President of ECCO, for being here and opening the speech, opening the event with me. And of course the EFCCA board for the collaboration. We will have also Alessandro Mozzi, who is the ECCO secretary. You will be elected. Do you have any particular bill about bowel disease? Maybe we can consider it. Thank you so much to the board of EFCCA for the collaboration in creating this event, and of course for the staff that has been working very hard in the next month. So I encourage you to participate on the event with your insight, with your question, because it's important not also attending and listening, but provide some information for the doctor that are here. And I invite you to see this event not like an arriving point, but like a milestone to have a brighter future for the patient we represent. Thank you so much. Britta?
It's this one. Yeah. Excellent, thank you. So, a very warm welcome to Stockholm from my side, and thank you for inviting me and giving me the opportunity to open the EFCCA conference here as ECCO president. And it's really my pleasure to be here, and it's, I think, an excellent environment to host the EFCCA conference within the ECCO Congress. And I'd like to explain why I think this is important and why we strongly will support you to do this in the future as well. We are here, and the topic of this year's Congress is crossing borders, and I'd like to share a few slides with you why we believe that we need EFCCA and the patient organizations more than ever to fulfill the strategy that I present to you now and that I will present later in the plenary to the ECCO family. So this is the conference, your conference hosted here within our scientific program. Over the last year, ECCO has worked on a strategy that will help us to focus our work for the next 5 years. And the strategy is REACH. REACH is an acronym, so each letter stands for one goal. So we have 5 clear goals shaping ECCO. But this doesn't mean that only ECCO is doing this. We absolutely appreciate that this reaching the 5 goals is only possible by that we involve the entire IBD global community. And this includes patient organizations, this includes healthcare people, this includes other organizations. And I'm happy to show them to you in more detail. So the R stands for rapid diagnosis and treatment, and I think this is a topic which will be predominantly be emphasized in the first plenary session in today's Congress. The Congress itself will focus this year on the E, which is equity, so equitable access to IBD care, not only in Central Europe, where this might be easier, it's not easy but easier, but also throughout our globe. And I think this is a very important goal, looking also when we see the incidence rising in parts of the world where there's not that much of care available. Then the A, which is attain sustainable IBD care in all measures, so monitoring, sustainable research, but also education for everybody, for patients, for healthcare people, so that we ensure a sustainable IBD care throughout the patient's life. The C, that's an easy one. We still haven't deciphered the real cause of IBD, so the C is the cause of IBD. So here we need more research by applying modern technologies, and also, and I think this is important, global collaborations and joining forces to clarify this issue. And the H, and I think this is something which you touched on already in your introduction, and I think this is something that has been neglected for a long time, in particular from our side, but is important. So you can have mucosal healing, so the gut can appear completely normal, but you can still feel not well. And I think this is a very important point, that we also need to care jointly about the optimized psychological well-being. And we need
we need measures to address this. And there are some out there, but I think here is room for improvement. Having said this, we want to reach together, so we need your help as well to reach the 5 goals and to make patient life with IBD better throughout the globe. What are we doing throughout this Congress? We have, and many of you have already seen this, so if you visit the A Gallery, which is somewhere over there, in the Congress Center, we have a crossing border exhibition where we show what ECCO is doing, what our corporate members are doing, what the DE&I initiatives are doing, and on the crazy topic of Together for Diversity, Equity and Inclusion. In addition, I think this fits very well to your topic of today. Today we are preparing currently a special issue of JCC on the topic of IBD across ages, in particular really focusing that it's not only the young patient that has IBD, but you get older no matter what you do, and the hair are getting grayer, so you need to take care about IBD in all age class, and I think this special issue will perfectly fit to your topic of today. And I think this is what I wanted to say. I wish you a very good conference this morning, and again, we are very happy to have you as part of our scientific program. Thank you.
Thank you, Britta. We are delighted to be here and involved. So the next part is, I'm going to call upon Isabella Haff, who's our head of communication within EFCCA, and she will take us through why did EFCCA decide to focus on the IBD in people aged 60 plus.
Yes, good morning everyone. I'm very happy to see so many of you here this morning because we're really excited to present to you today the preliminary results of a survey that we've been working on in recent months. But before we do that, I would like to give you a little bit of the context of why we decided at EFCCA to focus on this specific age group. And to do that, I would like to explain a little bit the way we work at EFCCA. We are a membership-based organization. We currently have 46 national IBD patient associations, and our work is defined through our strategy plan, which we elaborate together with our members. And in the strategy plans, we have identified priority areas of actions. In the year 2022 and 23, one of the priority actions was to look at how IBD impacts at the different stages of a patient's life. So we decided to look at the patients aged 60 and over. Why did we do that? Well, as you know, the population in general is growing very fast, and this is actually the same for the IBD populations. And there are estimates that in the next decade, 1 in 3 of all IBD patients is going to be an older adult. What's also surprising to us in recent years, we've noticed that there is actually an increase in the older onset diagnosis of IBD patients. So 10 to 15% of newly diagnosed people are 60 years or older. And when we looked into this topic, we realized that there was actually very limited scientific evidence for this age group. We did a very extensive literature review in order to really understand where do we stand at the moment in terms of therapeutic management with older patients with IBD. So as I said, we found that there was very little evidence-based treatment guidance. We saw that there is around 5 to 5.4% of all IBD patients in phase 3 studies are 65 and over. So in fact, that the treatment guidance is more based on observational data or indirect evidence rather than on the results of these studies. We also realized that there was no well-defined treatment target focusing specifically on older patients. And we saw that the use of long-term corticosteroid is quite common. We also saw, or the literature review revealed that there was a lower use of biologics compared to other IBD patients, and an increased risk for treatment-related complications. So in terms of corticosteroids use, that's down to short and long-term complications, and for the biologics, there is an increased risk of infection and malignancy. But we also wanted to hear from our members and from our patients. So in order to get the patient perspective, we organized a focus group meeting with 8 of our members, and it included representatives that were aged 16 above, in order to discuss from their point of view what the unmet needs of that age group was. We had lots of discussion and lots of things came up, but we decided to focus it down to 3 main areas. And I would say one of the bigger challenges they all found was that the challenge of managing the disease alongside age-related health issues, because as we grow older, you are also suffering from other age-related diseases, and it was a real, patients found it very difficult to manage the 2 aspects. And then, of course, it was maintaining good quality of life and keeping independence. And then we also said there isn't really a typical older IBD patient, so you can't fit them all into one box. And we had long discussions saying you could have a patient that is in their 70s having a relatively good health, whereas you could have another patient maybe 10 years younger with quite a difficult situation. So it really called for more patient-centric care. So having looked at the feedback from the focus group and at the literature review, we identified the following knowledge gaps. So a lack of large-scale clinical trial data that's looking at this specific group. There's a knowledge gap on the global IBD epidemiology and the characteristics in terms of frailty and comorbidity of older patients. There's also a lack of current management for older patients globally, risk stratification strategies, and we also found very little in terms of patient-reported outcomes, be it therapy goals or on issues of quality of life. So coming back to the strategy plan that I mentioned before, we decided to work on 2 different areas of activities. So one was awareness raising campaign. We started for World IBD Day 2022. The IBD has no age campaign because we really wanted to raise awareness and to highlight the impact that IBD has on the elderly. In terms of advocacy, we wanted to look at addressing the specific needs of people aged 60 and over. And in order to do that, we wanted to also generate more scientific evidence to stimulate discussions and research. We got in contact with, through our Dutch member, with the Leiden University Medical College. They've previously worked on this topic within the national context, and they were very interested in doing, to collaborate on a more global study. So in conclusion, the reason why we decided to focus on this age group was really to address the challenges that matter to our community. Also, as Britta mentioned before, to foster a more holistic approach, so improving not only the quality of life, but also the quality of care of people aged 60 and above. And we really believe that the mindset around aging needs to change. Thank you very much. I don't know if you've you've got any questions now or whether you want to do that during the panel discussions. I think we move on. Yeah.
Thank you, Bella. So we will now look at a working focus on ID across the ages, and we welcome Professor Alessandro Ramusi, who's the ECCO Secretary and future EFCCA Secretary, isn't it?
Thank you. Thank you. Yeah, for the invitation. It's a pleasure and an honor to be invited by a patient, because as I am used to say with almost all of my colleagues, we are existing because of you. Otherwise we won't exist. I will give a technical, trying to pass my thought overview on what means to me IBD in the elderly, and trying to explain all the difficulties that we are facing day by day in managing an elderly IBD patient, because of many reasons actually. And I will start on what Isabel before was mentioning. The epidemiology of Crohn's and colitis has changed and is changing. Today we are seeing that in the so-called new developing countries like China, like India, maybe like Brazil, there is a sharp increase of incidence of Crohn's disease and ulcerative colitis. And this was happening in the so-called Western world 30, 40, 50 years ago. And more or less here in Europe, we are in this situation in where the incidence is quite stable, is growing, but not so sharply like is growing in China or India. But people that receive a diagnosis 20, 30, 40 years ago are just staying with the disease, and they are becoming old people. So we are expecting in the near future to manage many patients with IBD over 60, 70 years, because it's a lifelong disease, as you unfortunately know. And so I think that in the next 20 years, we will face a lot of aged and frail patients in our patient clinic. There is a recent epidemiological study from Denmark on the Danish population that highlight that the mean age of the IBD population has increased today of 7 years with respect to 20 years ago. So patients are getting older with their Crohn's or their colitis. This is my first concept to stress. And do we have a definition? ECCO, so many years ago, I think, it was 2017, gave a rough definition on what does it mean IBD in the elderly. So simply, when IBD onsets at the age of 60 or over 60. And but I would like to stress what Salvo was saying before, that it is not only a matter of age, because we could have old people that are very fit, and old and adult people that are not fit actually, with comorbidity, with frailty. And this is the most important concept that I would like to pass. Frailty and comorbidity is the key of management of patients with IBD after some age. So percentage, we could say that we need to consider elderly IBD of patients with disease onset at a younger age, because they are becoming older, 20% more or less, but they are increasing, as I told you before. Or the pure elderly onset IBD, 15, 20%, they are growing like IBD in the childhood, that today more or less is 25% of new diagnoses are in the pediatric age. And we have specific challenges in this particular population. Sometimes we face the risk of misdiagnosis. We'll see later diverticular disease, for instance. The natural history is slightly different. And then we have concern, comorbidities, and also by our side and your side, an increased risk of side effects, both of drugs but also of surgery. So just to list, I won't enter into detail, but sometimes we challenge some kind of difficulty to have a diagnosis of IBD because it could be an infectious disease, it could be ischemic colitis, could be diverticular disease, could be microscopic colitis, lotus diarrhea, and we scope the patient and we don't see nothing. Or NSAIDs-induced enteritis and other conditions. So this is the first problem at the beginning of the story. The natural history is slightly different because we know that in the so-called elderly onset IBD there is more colonic disease in case of Crohn's, and there is more left-sided colitis in case of ulcerative colitis. The behavior looks like less aggressive than pediatric population and adult population. But these are data that date 10 and more years ago from population-based study, I think is from France. And then we have comorbidity, that is a really important topic, because we have a really practical implication also in managing patients with IBD that are old and or with comorbidity. Because the classical clinical manifestation of IBD can be confused by comorbidity, because the prognosis may be influenced, because we don't have evidence. Clearly, we don't have a lot of evidence of patient with Crohn's or colitis and some comorbidity. The use of drugs could be limited because we know that in some condition we cannot use a particular class of drug. And most importantly, at any age, but most importantly, like Isabel was saying before, we should set up a multidisciplinary team for aged people with chronic colitis, and there is a lack of this particular team in our clinics. I think worldwide that is not still recognized that we should have a multidisciplinary team, including also people trained to manage elderly patients with IBD. Some data. We know that IBD increases the risk of comorbidities, also in the young adult age. This is a report from the Manitoba court from Canada, and the final message is that IBD have an increased risk of comorbidity. You see cardiovascular, pulmonary, rheumatic we know, but also renal and also obviously cancer, diabetes, but also dementia or Parkinson. And this risk increase after diagnosis of IBD. So we know that people with IBD are at risk to have more comorbidities than the general population. And this is the first point. Second, the concept of frailty. What does it mean, frail patient, frail subject? There are many scores taking into account malnutrition, some psychological disturbances, simply urinary incontinence, senility, so reduction in walking. These are all concepts that may be included in the concept of frailty. And we know that people with IBD, elderly people with IBD, are significantly more frail than elderly controls. And frailty increase the risk, unfortunately, of mortality and of hospitalization. So it's a concept that for us is a little bit strange, but is a new way to consider a patient, an old patient with Crohn's disease or ulcerative colitis. And also we know that if we are in front of a frail patient, we have more risk of infection if we are starting an immunosuppressant. It has been shown in this large population from the US, in front of frail patients that are treated with biological immunosuppressants, the risk of infection is higher and higher. So keep in mind this, and we have to keep in mind actually, not only you, but we have to keep in mind in our day-by-day activity. And so the algorithm could be quite complicated. There are some guidance from the US for elderly patients in front of a new diagnosis. We are doing like we are doing for adult people actually, because we have to assess a prognostic factor, we have to assess disease phenotype. These are all technical aspects actually, but are important for us because in our mind then started to think about how to manage a person with Crohn's or colitis. And we could be in front of mild disease or severe disease, but always assess comorbidity and frailty, and also the functional status of the subject that we are in front. And then we could define the fit patient that could be treated like a normal patient, but also the frail patient. So take care and be careful, because it should be managed in a slightly bit different way. And then there is also the concept of health maintenance. So there is, if in the ideal world with a multidisciplinary team, also the depression screen, optimization of comorbidity, the screening of colon cancer, all the vaccinations that are important because many infectious diseases are preventable. So it's not simple, but this is what I have in mind when I am in front of a frail patient with Crohn's disease or ulcerative colitis. So what about medication? Because you need to have some kind of medication in most of the cases. And we are using almost all the medication, but with some particular problem or bias. Because you see we are using, if I say, steroids too much, in my opinion. Some immunomodulators were possible, and also biologic. But what comes into my mind is that we have to take care of some higher risk of infection, some interaction with other drugs that the old patient could take. And also, if you see on the bottom, on the right bottom, this comes from the US, I think. There is a trend to maintain the old patient on steroid. Why? Increasing again the risk of infection, osteoporosis, and all the side effects that steroid, because probably we are scared about the possibility to start on time some kind of biological immunosuppressant in front of an older person, and so all those steroids doesn't matter, but in the long term is not a winning solution, because we know that steroids, the risk of side effect is very high. The other problem, Isabel was saying that we don't have evidence, a lot of evidence from trial for elderly people, because you see the percentage of old people that are included in randomized controlled trial is very, very, very low. And the other problem is that this is quite new actually, is that it comes from Denmark. Yes, it's new because it was published 1 year ago. That patients with elderly onset IBD have a decreased chance of initiation of all the type of medication. And these are the report on the top during the first year and on the bottom during the first 5 years. You see, all the medication apart steroids are introduced later with respect to adult patients. So like if we have some fear to start effective medication in elderly people with IBD. I amend, this is my fault, but this is the situation today. So we should work on that. And the other that we are using steroid, okay, but we know that steroid in elderly people, not only in elderly people, but in particular in this study in elderly people, significantly increase the risk of serious infection. So why? is a question also to me. Why? We know, speaking about other kind of drug, that we have risk with people that is getting older, even if fit, thiopurines increase the risk of lymphoma in the young, in the adult, but if you see that the highest absolute risk is in patient older than 50. So azathioprine, 6-MP, and blah, blah, blah. And we know also that thiopurine increase in an age-dependent manner the risk of non-melanoma skin cancer, and you see on the right path that people over 65 years have the higher incidence rate of non-melanoma skin cancer after treatment with thiopurine. So this should be taken into consideration when choosing a drug, or more than one drug, to treat an elderly patient with IBD, with or without comorbidity. And then biologic. This is a good issue, because we know that frailty, comorbidity, and not only age, may increase the risk of infection and mortality in elderly people. Here in Italy, we reported many years ago with TNF inhibitors, but I think that, and it has been confirmed in Belgium in this study, but now we have many other drugs, many other biologic, and you know that always from Italy that there are different kind of biologic. In this case, vedolizumab that could be safer in elderly patient because of the mechanism of action, and you see here this is a comparison with TNF inhibitors, and also we have another type of biologic that is ustekinumab that is considered safer than other drugs in using in elderly patient with IBD. So we have a wide variety of choice to start a therapy on time and not delaying to treat a patient because we have a fear that the patient is frail and then could have different kind of side effect. Not all the drugs, in my opinion, are suitable for old people. JAK inhibitor, for instance, I would be very careful to start in elderly people with comorbidity because they have some risk. But again, in front of a fit old patient, I think that we should consider to introduce timely, possibly every kind of medication. The problem is that in part could be the medication, but in part is important to screen the patient since the beginning and to understand what is, like for an adult patient, the best treatment to start timely in that particular, I would say, person and not patient. Problem of surgery, we know that there is a higher risk to undergo to surgery, mainly in ulcerative colitis in elderly people with colitis. These are reports from Canada. But most important, we know, sorry about the slide, it's quite crowded, that elderly people have higher risk, perioperative risk to face complication, even also mortality. There is a higher rate of laparotomy instead of laparoscopy in elderly people. This has been reported from the, I think, from the US a few years ago. So at the end of the story, this is my last slide. I think that we should deserve a separate treatment algorithm for elderly patients with IBD. In part, considering them like adult patients, so screening, prognosis, phenotype, but also we need to assess frailty, including comorbidity, and to consider the patient fit or not. Age is not a matter, in my opinion. Is the patient global status that is important? And this is my view. I hope that I passed my opinion to you and you have understood my approach to elderly patients with IBD. I'm ready for discussion if you want. Thank you.
Is there any burning questions at the moment? if anybody wants to ask. No. Oh, hi Nidhi.
I think Professor Alessandro, thanks so much for your presentation. I'm very, I get very charged up when it comes to comorbidities. I'm a Crohn's disease patient diagnosed with 4 other conditions over 8 years. But my main concern is IBD specialists are only looking at IBD. Not enough research is even happening where there is a collaboration with other illness background specialists. But that is the area I'm looking for, that when there's no research, there is no outcome. And then how do we treat? Because if we are only looking at one specific area, and we are focusing on elderly, which is fair enough to look at elderly, but like you also mentioned, it can be any age group. I was 40 plus when I was diagnosed, and then had multiple issues. But I bring my example of hope to everyone, that when my Crohn's disease medication was stopped, because I was in mucosal healing, my fibromyalgia issue went down, small fiber neuropathy went down. So in 6 months, all my medication was cut. I'm on 0 medication for 4 years.
It's interesting, and I completely agree with you. The issue of elderly IBD is relatively new for us because, as I presented in the first slide, the concept of older and older IBD population is, I would say, not new, but quite new concept for us. And I completely agree with you that we should work across the indication, with the geriatrician for some aspect, with oncologist for other aspect. We are used to work with specialists of immunomediated extraintestinal manifestation, rheumatologists, dermatologists, but not with other specialty. And this is probably some point that we have to take for our future to better manage a situation like your situation. Sorry about that.
40 elderly.
Oh, one more.
Yeah, also a question to, oh no, I don't remember your name, sorry, but the professor, I was wondering if there was like, do you look at all chronic diseases within comorbidity, or is it like in special areas of the body? Like do you look at the skin, the lungs, the muscles, or is it only like in the digestive system?
So well, we are physicians, so in theory, when we meet for the first time, Flavio, a person, we are speaking to the person, asking not only about how much time your bowel open during the day, or you have tummy pain, or you have arthritis, or you have pain in your eyes, or you have some skin manifestation. We have to speak deeply with the person, asking about past medical history, about current symptoms, past symptoms, to try to understand if there is some health going on. And so there is no limit, in my opinion. Cardiac problem, breath problem. So it seems simple, but it is like we should do as a physician. And then, in case of some kind of suspicious, we should go and investigate also outside the intestine, or calling some other colleague, like in a multidisciplinary team, and let them to proceed for a different kind of problem. This is my view.
Has there been any studies done on... has there been any studies done on what kind of diseases that are most likely to be comorbidity with...
Well, in IBD, I mean, The more you investigate, unfortunately, the more you find, because a few years ago, it has been shown an increased risk of cardiovascular disease, also in adult young patients with IBD. There is a risk of kidney disease. There is a risk of pulmonary disease, bronchiectasia, for instance. And very recently, also an increased risk in elderly people of Parkinson, of dementia, and psychotic syndrome. So if you do epidemiological study, unfortunately, is a chronic inflammatory disease, and chronic inflammation could act as a trigger for many diseases. I'm trying to speak in a simple way, but chronic inflammation is probably the trigger for many other associations, and this is the reason why it is very important to fight against inflammation in a patient with Crohn's disease or ulcerative colitis.
We might just move on. I do believe Professor Mercy is sitting on, I think, so we'll be here. So just to keep on schedule, because we will have a panel discussion and more Q&A later on. Is that okay? Just to keep, we went from having nobody to a number of people. So we now will invite Anne Vons and Isabella Haff to the stage to look at the preliminary results of the survey.
Yes, hello. We would like now to ride you through the results of the survey that we've carried on, and thank you very much, Alessandro, because I really feel like, you know, it's we're going the complete opposite direction, and I mean, it was really also for us, the survey was also intent to really stimulate more research and more discussions around the topic. So maybe I'm going to start, and then I give the floor to Anne. So, if you want to say, yeah. So the overall aims of the survey was to study in the global the older population 16 above. The more specific aims of the survey, we wanted to look at the epidemiology of IBD, the impact of IBD on quality of life, reported therapy goals, and self-reported comorbidity and frailty. Now a little bit about the design of the survey. The survey was initiated and developed by EFCCA in collaboration with our colleagues from Leiden University Medical Center. As I mentioned previously, the contact was kindly established through our Dutch member. It was an online web-based survey, but then of course we realized if the target group was 16 above, we thought we had to be a bit more innovative, or maybe go back to the olden days of working. And we discussed this, and some of our members actually decided to print paper copies. They sent them out through their standard magazine, and then I think we had to fill in manually around 800 paper copies. So, but we really felt that it was important to be as inclusive as possible. This survey was available in 21 languages in the 46 countries of our member association. And I would also like to say here a big thanks to all our members who helped us with the translations, because we really want to make sure that the translations were patient-friendly. We had a discussion yesterday about sometimes the translations, if they're done by the translation companies, they really don't reflect the language of the population. So our member associations really did a great job in making sure that it would be understood by their local population. We decided to launch the survey on 19th of May, which is, as you all know, World IBD Day. So we thought it was really a good occasion to create as much noise as possible around the survey. And it was open until 30th of November last year. And then it was distributed through our national IBD associations. In terms of the design of the survey, it had 31 questions related to demographics, IBD characteristics, IBD medication, treatment goals as reported by the patients, and self-reported comorbid conditions and frailty. The inclusion criteria was to be age 16 above and to have an IBD diagnosis. The exclusion criteria, any patient not able to understand and/or fill out the questionnaire, and any questionnaire with one or more missing answers. We need some drums now for the preliminary results. So in total we had 2,191 answers. We had to exclude 194 because they were not completed questionnaires, and these were mainly the paper copies, because on the online version there was no way to continue the survey if they didn't tick all the relevant boxes, so unfortunately we had to exclude these. And the responses we evaluated for the final analysis is 1,997. In terms of the geographical distribution, you see here I would say the top country, and it makes sense because of the history with our members and the research that's already been carried out, was from the Netherlands. We had 847 responses. Second came Norway, and I know for our colleagues it was also a very important issue at that time, with 162 responses, and Italy with 151. And you can see through the whole list, there's a little sort of focus in the European region, the geographical distribution. In terms of general characteristics, the average age was 67.3 years. We had 39% of responses from the male and 61% from female. And in terms of the educational level, 46% were higher education university, 47% had completed high school, and 7.1 middle or lower school. And in terms of the employment status, it wasn't a big surprise. 45% were retired, but 15% were working full-time, 10% part-time, 5% declared disability status, 3% not working but were not retired, 2% volunteering work, and 1% were on IBD-related sick leave. In terms of the IBD characteristics, 51% of respondents had Crohn's disease, 44.8% ulcerative colitis, and we had a 4.2% of IBD unclassified. And in terms of the IBD duration, for Crohn's disease it was 28 years, UC 19 years, IBD unclassified 10 years. And the clinical disease activities was for both Crohn's and ulcerative colitis 31%, and much higher for the IBD unclassified 57%. I think at this stage I would like to invite Anne to the floor and to continue with the presentation.
Thank you, Bella. Yes, I will continue with the reports on the IBD medication. We were quite curious what the medication was the patients got, because there is a lack of guidelines, and 82% reported the use of one or more IBD medication. This is for the whole group. 37% used aminosalicylates, 35% used one or more biologicals, and 8.7% used prednisone or budesonide. And when we look a bit further into the types of IBD, for Crohn's disease, 79% used any medication. And in this group, 44% used a biological. And for the ulcerative colitis, this was a bit lower, 26%, and the share of the aminosalicylates was much higher as expected in this condition, 58%. And the use of prednisone or budesonide was, well, I think expected was lower than we expected, and also when we look at the numbers that were just presented by Professor Omunzi, it's lower than the numbers there. Then I would like to go to the therapy goals. Patients could choose from 12 therapy goals, and they were categorized into more medical therapy goals and to quality of life therapy goals. A patient had to report the 3 that were most important to them. And the medical therapy goals included if they wanted to experience less abdominal pain or decrease inflammation, postpone surgery, getting the weight they would like to be, stop the use of corticosteroids, or decrease diarrhea or incontinence. And the quality of life were mobility, the social life, maintaining or restoring a good mood, the body image, not feeling fatigued, which we'll see later, or restore the sexual activity. And these were the 3 most commonly reported therapy goals by all patients. And the most commonly reported was that they did not want to feel fatigued. 56% of the patients reported that this was one of the therapy goals they want to achieve. The second most reported goal was to preserve or restore a good mood. As already mentioned, depression and mood disorders are common in patients with IBD, and I think this really reflects that it's a big issue. And the third therapy goal was to decrease diarrhea or incontinence with 32%. It's a slide with a lot of information. We stratified the percentages by type of IBD. Then I will walk you through it. For Crohn's disease, the top 3 was not to feel fatigued, to preserve or restore the good mood, and to decrease diarrhea and incontinence. For ulcerative colitis, this was only the third was different. It was to preserve or restore social life. And for IBD-U, it was a bit different. The most important was to decrease diarrhea and incontinence. The second, not to feel fatigued, and the third was the good mood and the social life. Then I want to elaborate a bit more on the frailty. The previous speaker already spoke about it, but I will highlight some different aspects of it. Frailty is defined as an age-related state of physiological decline that leads to an increased risk for adverse health outcomes. It's a relatively new concept in IBD, but it has been applied in oncology for a bit longer. So there is some more evidence in that field. And I wanted to illustrate the concept of frailty using this image. On the y-axis you see the functional abilities of a patient, whether a patient is independent or dependent, and this reflects the level of frailty. And the blue line represents a healthy, fit, older individual. And you see that when a stressor, which can be, for example, a urinary tract infection or a pneumonia occurs in this patient, a patient has a relatively small decline in functional abilities, quickly recovers and returns back to the baseline. But in this patient, this is a frail older patient, the baseline level is already lower of functional ability, and you see that the decline is much bigger, and you see that this patient crosses the line of dependence, and that the recovery of this patient is longer. There is a chance that this patient does not come back to his baseline abilities. And this is what makes this. This is why these frail patients have an increased risk for complications. And in IBD patients, this includes a risk for hospitalization, readmission, low quality of life, and mortality. Most studies that are performed are retrospective studies using screening methods. There are only 2 studies that prospectively investigated frailty. In Leiden, we performed a cohort study in 400 older IBD patients. And these patients, in these patients, the prevalence of frailty was around 48%, which is quite remarkable. And there are several ways to screen or measure frailty. In geriatrics, the gold standard to measure frailty is by performing a geriatric assessment, which is a comprehensive assessment of all body functions. So you look at the comorbidity, the somatic status, but you also look at the mental state, so the cognition and the mood. But this is not feasible to do this extensive assessment in all older IBD patients. So that's why screening instruments were invented to screen for frailty and to see which patients would benefit from this geriatric assessment. And one of the screening instruments is the geriatric 8, which is a questionnaire consisting of 8 questions. This questionnaire is also commonly used in the oncology field. And when we incorporated the geriatric 8 in the survey, and the results we got was that 40% of the respondents of the survey was frail based on the geriatric 8. And when we look a bit more into the questions of the geriatric 8 and the answers that were given by the respondents, was that mainly the questions on nutrition. So, for example, the first question, food intake in the last 3 months, around 30% reported an abnormal answer, indicating that they were eating less or much less than normal. A lot of patients reported weight loss in the last 3 months, around 35%. Quite a lot of patients had an abnormal answer for the neuropsychological question, which asked about if they were forgetful or depressed. And so we already saw in the question about the therapy goals, here around 30% reported to be either a bit forgetful or depressed. And then we see, in addition to the nutritional status, that 23% reported an abnormal body mass index. Then we were interested in whether patients with or without frailty had different therapy goals. Surprisingly, they were more or less the same, the top 3 at least. The only difference was that patients with frailty reported that they would want to have a decrease in diarrhea and incontinence, while patients without reported frailty wanted to restore or retain their social life. Then a bit more about the comorbidity, also mentioned previously. We tried to distinguish in the survey between extraintestinal manifestations such as uveitis and other comorbidity. And as we already heard, that IBD patients have an increased risk for certain comorbidities such as cardiovascular disease, neuropsychological disorders such as dementia or Parkinson's, but also the metabolic syndrome with diabetes. And we, in the survey, there was a list of conditions that patients could choose from, and then there was an open question in which patients could report other comorbidities that were not included in the list. And comorbidities are very relevant because they can complicate treatment. For example, with the JAK inhibitors, they are currently not recommended in patients over 65 years old or patients with a history of cardiovascular disease. So as I mentioned, patients could report the comorbidities based on a list. 35% of the patients reported to have no comorbidity, but the rest of the patients did. And the most commonly reported comorbidities were arthritis with 29%, asthma with 13%, heart disease with 10%, which was quite high, diabetes with 9.5%, and cancer in the last 3 years 6.4%. And this leads us to the summary. These were the preliminary results, so the final results will follow. But the EFCCA initiated this survey among the global older IBD patients, and it was a patient-centered survey targeting a broad and diverse representation of older patients with IBD. I think we had a very large number of respondents, around 2,000, with a mean age of 67.3 years old, and around 2/3 was female. We have good insight in what kind of medication these patients use and what they aim important in their therapy goals. And they reported fatigue, mood, and their urine incontinence to be the most important. And we have more insight in the prevalence and the occurrence of frailty and comorbidity. So I think to conclude, these are very promising preliminary results, and we will hope to present the final results in the final paper very soon. And we would like to have a great thank you to all the patients who participated, of course, the National IBD Associations and the EFCCA members of the team. Thank you.
Thank you very much, and it's great to see the preliminary results, and I think there's a lot of interesting information there, so no pressure for the final results. We're going to have a panel discussion now, so I will be asking if Daniel Stinstein, who is a former leader of the EFCCA youth group, we will have Raffaella Campanella, who is an IBD patient representative, Anne Vons, who will be up again, and Claudia, who is the survey coordinator as well. You want to come up?
I just would like to also say that unfortunately Paolo Girardi, who's been working with us on the service, while he couldn't join us today, but we were very pleased that Professor Armuzzi has agreed to join the panel discussions, so I would like to invite you to the floor.
Oh, the pressure. I'll let you go there. I don't want to say I'm the chief, no. I'd rather hand the microphone over to you to be chief. So, you can hear me, yes? Yes. So I have some questions from this morning's sessions. Raphael, I'm going to speak to you first, is that okay? No, and you break the ice. Not too fast. For you, because you were involved with focus groups, is there a typical IBD patient?
I think to be a typical IBD patient. By the way, I used to summarize my IBD in some few figures. Let's say I am 75. I had three major surgical operations. I had 3 chronic diseases, apparently not linked together, but after Professor Arnozzi's speech, I'm not so convinced now. And they take 6 pills a day. So I think it's quite normal now. I think I'm close to the average. But the Gaussian curve is wide, so...
My question to you, your IBD is in remission now. Sorry about.
I think it's a
You define
because I took away the colon, so
you are in remission.
Let's say like this.
This is important because taking 6 pills per day with other 3 comorbidity, if your IBD wasn't in remission, probably you wouldn't tell that I am like the other.
IBD is a systemic disease, so I can believe that can touch many other parts of the body.
And Professor Armuzzi was speaking about a multidisciplinary team, and I think all patients here would consider a multidisciplinary team very important regardless of your age. But I'm glad you brought up your figure of your age, but considering you're over 60, do you feel as a patient that is so much more important to have that multidisciplinary approach with your comorbidities?
Of course it is important. They feel to be supported by a lot of specialists. But I have to draw your attention that unfortunately the situation is not so homogeneous, at least in my country. I don't know in the other. So people that has the fortune to live close to big cities, they can have a very good support from the health authorities. While who is living in the mountains or in some part of Italy in the south and so on, in some part of the south, they are really unlucky. And this is, I think this is a matter of, has to be thought by the health authorities. It is a matter of organization more than clinics. Normally people give for granted that the cares are okay, but all the other supports often are missing.
Daniel, I just want to come to you for a second. We were speaking last night at dinner and we realised you're no longer youth, just pointing out. But you are the former chairperson of the youth group, and I suppose, how does a survey like this impact you? Because you're a few years off, a good few years off, being part of that over 60, but for younger people, what is the impact or implications a survey like this can have?
I can see it going two ways. Either you get depressed about the results and think, okay, I'll have 3, 4, 5 comorbidities when I'm 60, or you get good, motivated and start building up your social support, because I think that's also an important thing in getting older. If you have the lack of the social support from your family, from your friends, from the society in general, you have a higher risk, I think personally, of getting into a frail patient. But also the matter of exercise. So the physical exercise and maintaining a good mental health. I think so. So we're standing at a pathway where we need to choose, as a younger generation, where would we be as IBD patients when we're older? Because I have a comorbidity myself already. I got a drug-induced migraine. So it's coming, but we need to always look at the positive side of things, I think, to have a better elderly life.
I thought it was interesting to see, and as patients again, we speak a lot about the quality of life, but I think it was very interesting to see it coming through very much so in the survey as well. And when I looked at the geriatric 8 results, it was one of the top, which was really interesting to see that quality of life was higher than food, higher than weight, and also based on your disease. And can I ask you, was there anything from looking at the survey from a medical aspect that you were surprised at the results of?
The use of prednisone, actually, yeah. Especially U-slide and U-slide, they were very different, because you thought that, or you meant that the use of prednisone were quite high in elderly people, and you actually documented that it wasn't that high. But also the difference between Crohn's disease and ulcerative colitis, when you're talking about immunomodular treatments and biological treatment, that it actually has such a big difference in between the two diagnoses. That came as a surprise for me.
And Anne, from your perspective, was there anything that came as a surprise for you?
Me?
Daniel, you'll have to stop talking.
Yeah, I think I can agree on the prednisone part, and also the questions on the geriatric 8, like the relatively high prevalence of frailty in the respondents. But I think it confirms our thoughts that frailty is prevalent.
And Professor Missy, I'm going to put you on the spot. In relation to the results, was there anything in your role as ECCO secretary that you think would come as a surprise?
I was surprised about the use of steroid, because it's quite low, and I don't know if there are country difference, because probably you know, but there could be country difference. I have no idea, but it would be interesting to know difference from country to country, because as a scientific organization we could act on a single country if there are discrepancies. Well, I mean, the concept of frailty, the self-defined frailty, that for us is quite a new term, as you know very well, is in line on what I have presented before, that is higher in patient with IBD with respect to the general population, so it does not surprise me at all. And this should be another aspect that need a lot of work. A clear definition of frailty in a patient with Crohn's or colitis, that we lack of this, I think, research and so on.
Yeah, I think that was something, the element of frailty and what defines frailty was surprising to me, and especially I think the geriatric age, because I think people can think frailty is just physical rather than those elements. Claudia, you're a medical writer and you were the survey coordinator. Was there anything that stood out to you, considering your background in scientific advisory and medical science?
Actually, I was really impressed and happy to see that the quality of life stood up in the survey. So this is a survey that came out from patients, and we are going to publish their opinion, their voice, and I think this is going to be like the most important points, that this is coming from those who will benefit from the medicines, from the healthcare. So I think it's the most important thing, asking them, which is your goal? What do you need from this healthcare service that we're giving to you? So I'm pretty sure that there must be a collaboration and dialogue between healthcare and patients. So it's not just the best medicine, but the best quality of life related to the medicine. So I think that was a really important result that we had. And I was happy to see that also biologics were actually one of the most used medicines in Crohn's disease patients, at least. So it looks like that what we're doing is actually useful.
Raphael, would you agree with that I suppose the quality of life is, you said you were in remission, but 6 tablets a day? 6 tablets a day. So 6 tablets a day equals a healthy Raphael medically, and remission. So would you agree though, as an over 60, that the quality of life is hugely important?
Of course, I live with the 6 pills a day, and I consider them a problem that I have to face with. Of course, they cooperate in my health, my quality of life, of course. But in my mind, behind my mind, there is a question: what happened in few years in advance due to these pills or due to these comorbidities? And this is something that is more than a pure pain, let's say. Not only for me, but I see also for many other patients that I have the chance to talk with. Quality of life is much more important than the clinic subjects, let's say.
And Daniel, speaking from a few years to go till we reach that age of over 60, is the long-term, I suppose, IBD treatment of what's your view on that for over 60s as well? Because obviously the results there, which probably we didn't have that data before.
No, I was thinking about that during your presentation, Professor, because does the comorbidities and the frail patients have anything to do with the late diagnosis? Early diagnosis, does it have something to do with how severe the condition is of the colitis of Crohn's? or does it have anything to do with side effects of medicine giving at an early stage or late stage, or how you take in the medicine, and do you obtain the medicine? How do you, all these questions here? What comes first? Is it the early diagnosis, the late diagnosis, many years of severe disease? Is the side effects of medications? What is that is causing the comorbidities and the frail patient when we get about 60?
Well, in my opinion, looking into the biology of the disease, if you do not manage trying to settle down the inflammation, you increase your risk of all of these possible comorbidity. So starting with, I wouldn't be too much sophistical or too much scientific, but all of you know that the pathogenesis of inflammatory bowel disease is a very complex pathogenesis in which there is an interplay of different causative factors: food, environment, genetic predisposition, microbiota we put in a person that has the predisposition to have an exaggerated immune response inside the intestinal wall, the intestinal mucosa, but they could become systemic. So it's a sort of systemic chronic inflammation that when start may trigger many other conditions. Still we do not know actually. But my message is that the soonest is possible to settle down and to maintain settle down inflammation, probably the lowest is the risk to have also many other conditions. I don't want to say that if you keep inflammation completely under control in your life, you will not have any other comorbidity, but you reduce your risk, because we have shown and we have seen that IBD are linked to many other non-intestinal conditions and non-immunomediated conditions like cardiovascular disease, like pulmonary disease, like and I think that inflammation, chronic inflammation is the link.
Does that answer your question, Daniel?
It does, but it creates one more. So
I'll allow you one more question, and then we're going to go to the audience for some questions.
Exactly, but if you take down inflammation and keep inflammation low away, for what cost, how much medicine can a body handle? For how long time?
We should, now I'm speaking as a physician, when I speak to one patient person in front of me, trying to explain a choice that we need to share together, because it's the modern way to have, not just prescribe, go. And I'm trying to understand also which kind of life that particular person is doing. So the concept of quality of life is a generic concept, quality of life. My quality of life is different from your quality of life or your quality of life. So speaking to the patient and trying to understand what are the priorities, and then balance. And it's not a matter of number of medicine, it's a matter of balance. We are not perfect, you are not perfect. So it's balancing benefit, willingness, aspiration, risk. Is not only benefit risk by the technical point of view, but also there is a third variable that is the most important one, that is the patient. I mean, it's not magic.
We like to think it's magic as patients. Can we go to the floor?
Excuse me. I had a question to Professor Muzzi.
We're a very active panel that we're asking questions.
That question. You underline the fact that the doctor has to talk with the patient, try to understand all the aspects. But I see that an improvement area in these magic moments of first contact is not to show hurry, because every time I had the possibility to have a visit for myself or talking with other patients, many times we don't talk about drugs but we talk about the feeling, talking with the doctor or the nurse. So when they show or they let us perceive hurry, you have hurry, you work in hurry.
It may happen, sorry.
It may happen, it happens often, it's human, okay. This is a problem for them.
I know.
This is a problem.
6:45 in the afternoon, after having visited 25 patients, sometime may happen. Sometime, yes.
I can believe you, but for me, my problem is 100%.
I know. Also at 6:45 in the evening.
So if we just go to the floor, you need a microphone. If there's any questions from the floor.
Sorry, Adam, I think...
Yes, there was a question there. Yeah.
I don't know if it's a question. So I'm Verena, I'm from Brazil. I live in Portugal, but I'm from Brazil. I have Crohn's disease for 30 years. And I become dietist because of me and my colleagues. And I would like to put here something to complete, if you permit. So, yeah, I'm a dietist, nutritionist. I believe that we, in our association, we needed to make effort to communicate from doctors and patients that it's so important, the medicines, okay, but it's very important make the patients understand that non-pharmacological treatment like diet, and we know it's not only Mediterranean diet, we know it's only this, but diet, sleep, and strange muscle, because it's incredible when the patients go to the gym and really dedicated to make your muscle strong. The body make responses so incredible for medicine, for diet, for everything.
Agree, and we acknowledge that in the last maybe 6-7 years, nutrition and diet has become very important also for us physicians. 10 years ago, 15 years ago, it was very common to say to the patient, you can eat whatever you want, we don't know. Avoid to eat fibers if you have a stricture, and nothing else. Today, we have a lot, improved a lot. I agree about physical activity because we know that there is quite a new evidence that physical activity can maintain.
In many diseases, not only IBD, many diseases.
Yeah. So you're right.
Daniel, can I just quickly, because I know there's a question here as well, can I bring you both in on that? Because Daniel, I know from a patient's perspective about the importance of physical and sport.
Yeah, I totally agree that physical exercise is very important concerning IBD, but also concerning side effects and comorbidities. Because if you have osteoporosis, for example, you know that strength exercising will help in prevent osteoporosis. If you have the cardiovascular diseases, the pulmonary diseases, you can increase your VO2 max by doing cardio exercises. So there's a huge impact, not both on IBD and maybe also the microbiome, but especially the side effects of the medicine and the comorbidities following IBD.
Anna?
Yeah, and I wanted to add that many of the frailty interventions are also centered around nutrition and physical activity to strengthen patients.
Yeah.
Well, one thing regarding this specific case of nutrition that I agree completely with you. Also from an elderly point of view, the request that I received from the patients, and I'm responsible for an area of the association in Italy, are many times related to nutrition, but not only nutrition, also how to control the body. Gym, of course, but other practices like yoga, for example, mindfulness, breath control. So this should be also pushed by the physicians or by the nurses, let's say, during the visit.
And I think that's something that we are seeing changes in with the physicians, is that it's, I suppose, down to the quality of life. You ask me to do yoga as my doctor and we won't have a good relationship, but maybe you would like to do some yoga, and it's about getting physicians getting to know their it's different for every patient. Adam, I think you had a question there?
I'm Adam from the Israel Association. I was wondering if you see any increase of the amount of elderly diagnosed, or is it us better diagnosing them, or do we address them? Especially, is it something new? And the other question is, if you starting to see or seeing some kind of differences between groups, between ethnic groups, countries, and stuff like that.
I'm going to make you chief on this.
No, well, if we are seeing an increase of diagnosis of in different group, you want. I mean, I was at the beginning of my presentation, I was saying that in China, 40 years ago, they didn't know IBD at all, just infectious colitis. And now, if you think that Chinese people that have migrated from the countryside to the big city, Beijing, Shanghai, and there is a lot of the new diagnosis of IBD. So this clearly is environmental lifestyle, I think, in the first generation, like it was in the 80s in the Midlands, in the UK, that there was an immigration of people from India, Pakistan, and the first generation got a lot of IBD. In the Arabic country, there are some ethnic group that inbreed together, and some colleagues from that area told me that there are very bad phenotype of Crohn's disease. So, also in Brazil, Flavio, in the last 30, 40 years, I think that the new diagnoses have increased, because we can consider Brazil a new industrialized country. So environment makes the difference. It's not only genetic, but still we do not know. What about probably many things, not only one.
I think it's back to that $1 million question on what causes it, and there's not that one answer. Is there any other questions? Oh, I have two.
Hi, good morning. This is an excellent session. I'm Flavio from Brazil. I'm completing 40 years this year of managing IBD patients, so it's a lot. I have a lot of experience. And I want to say that I really fully agree with what Alessandro said. And I guess the treatment, the management of IBD should be divided in 2 steps. The first step is bringing the patient into remission, so improve the symptoms. And then the patient gonna feel safe because he gonna have the disease under control. And then all the rest is very important, but it's a second stage. So it's keep the patient on mission, keep the patient well, and then introduce diet, introduce everything in order to make the patient have a better quality of life. And at this point, it's very important to have a multidisciplinary team with a nutritionist, with a psychologist, with a physical therapist, and whatever. And even with very diverse medical team, which includes like a rheumatologist, an ophthalmologist, a dermatologist, and others. So I guess this is very important. And nowadays we're becoming very ambitious in terms of having better results, in having healing, in having histological healing, and this is very good. And about the medications, even the pharmaceutical companies, they are worried right now about safer medications and more comfortable medications. So I guess from my beginning, when we had just sulfasalazine and steroids, we are in a complete new world, which is very, very exciting and very, very good.
You know, I think I would agree with you that as patients it has progressed. I think also as patients we are slightly impatient, so we don't always wait for our multidisciplinary team to get us well, keep us well. We want to be well very quickly, which is, we're slightly impatient. Nidhi, have you a question?
I was quite intrigued by the statistics shared when the survey results came out. And it's interesting to see the part where patients are saying fatigue is the issue that needs to be sorted out. And what I've realized is there is no medical device to measure fatigue, firstly. So many patients are then brushed aside that don't even talk about it. Second component in that same issue is many women are ignored when it comes to measuring fatigue or pain. So there's some level of bias there. The second component on fatigue is there is no specific medication to manage fatigue. So there's a huge gap there when we are looking at what the patients want and what are the options available. So that is what I wanted to say.
The fatigue is a big issue of research today because we don't know why. Simply, I admit, when a person feels tired, and by the technical point of view, everything is okay, anemia, no anemia, mucosal healing, yes, histology, yes, B12, yes, vitamin D, yes. And why you report fatigue? I don't know. So this needs a lot of research. Maybe in the next 5 years something will come out.
And were you surprised with the results on fatigue?
Not that much, because it's such a big problem. Yeah, we know it's a big problem, and I think this confirmed again that it remains a problem.
Is there any other questions? Oh, Sal. No, you don't have a question.
This is a question for Alessandro. Do you think the use of artificial intelligence in the next years could help you to find the origin of the disease, or to find, or better to find a final cure for this disease?
Well, $1 million question. I hope. I mean, it's a complex disease. Many aspects should be incorporated, and put all together, and I'm sure that when we will have understood what is important from the genetical point of view, what is important from the environmental point of view, what is important, which bug is important in the microbiota, and putting together all the biological and molecular aspects, I'm sure that artificial intelligence will help just running together all the possible determinants, and also help us and you to have a sort of prediction of disease course, but it is futuristic still. Sorry.
You're really getting the $1 million questions. If I could have just some closing thoughts from each of the panelists in relation to, I suppose, the survey results and the event, and I suppose a bit of positivity for our future maybe. And so Daniel, would you have anything, I suppose, from a younger generation that to close on?
Yeah, I think that the idea of a multidisciplinary team is maybe the way to go, to have a full treatment of a patient, of an IBD patient, because maybe we can't explain the role of fatigue in numbers or in measurements or anything like that, but you can have mucosal healing, we have not anemia, but you still have the psychological impact of an onset disease. For me personally, it took me 4, 5, 6 years just to accept the disease. And of course that causes fatigue and many other things. When do you get diagnosed in life? What are your social support? All these things matter, and if you had the multidisciplinary team where you had a psychologist, you had a physical therapist, you had different doctors and specialists, I think it could help the patient in improving faster and more.
Anne, is there anything from your side? Is there anything that you wish to close with?
I think we need more clinical trial data on the medications as we already mentioned, and I think we need more data on frailty, so the incorporation of the geriatric assessment and the multidisciplinary team, how we can actually well incorporate it in clinical care. Yeah.
And Raphael, I have a final question for you in one sense before I go on and we close. Have you any words of wisdom on how we get to 75 on 6 pills a day? Any tips for us that still have to get there?
No, sorry. Can you reformulate the question?
Yes, no. Can you, I suppose, to close off the session, give us your final thoughts on the survey results, or how we can all get to your age on 6 pills? Actually,
I was very happy to see in the research that some intuition that I experimented on the ground are really there. In particular, I don't know if you've noticed, but quality of life is much more important for the patient than the single clinical aspect. The patient gives for granted that he's cured in a good way, let's say. But there are many other aspects that, in my opinion today, they are not so investigated. And the research give us this evidence.
Claudia, anything from you?
So I think that we raised up many points of discussion for the future. So thinking about also the nutrition point, we didn't include it in the survey. It was just too much thing to include in one survey. But I think that it's important that again that solutions are found both from the medical sides and from the patient side. So if we know there are some things are lacking in the medical healthcare system, and we know that it can be very slow, the change in that sector because of politics or organization or countries' differences, maybe we can start doing something from the patients, also collaboration with nutritionists, collaborations with gyms, collaboration with other activities. And so I think that these results are important for doctors, for pharmaceutical companies, but also for patients. So everybody should take actions from these results, and I think that this could be also an example for other sectors. So we can do it, so you can do it.
Absolutely. And over to you.
I want to say, I think that this is an example of collaboration between patient and physician. One of the many activity and initiative that EFCCA has performed, and I think is the right way to act. Don't do by yourself. Try to involve also people that take care of you. This is my message. Then you will have result. You analyze together from different part of view, and then you act, because we have the political power to act as a big patient organization. We are not us. You are you.
Yeah.
Thank you.
I think if it's okay, I'm going to close it from sitting down, not just to stand back up. Oh, Frida, have you a question? Okay. No question. Only which? She wants to testify.
My name is Frida, and I was diagnosed when I was 27. 45 years ago, so I'm still here. And when I look back in the past, the progress I made with all the medication we have, we tried them all the medication. Until now, I had 4th surgery, but I'm so grateful. We have the progress, and for the young people, don't lose the hope. It will be better in 20, 30, 40 years, I'm sure.
Frida is some woman. I was walking, well, we were looking for transport this morning, and Frida and I were walking, and she's like, I'm the elder of the group. You're not. you're the young one. So just to, I suppose, close the event, we'd like to thank you on behalf of the EFCCA staff on board. We'd like to thank you for attending. We'd like to thank all the participants in the survey. Particularly like to thank Britta and Professor Alessandro, because things like this don't happen overnight, and collaboration doesn't happen overnight. It's something that is built on over a period of time, and so it was fantastic to be included in the scientific program, and we hope this is further starting point of a beautiful relationship. And maybe next year you might have the answer to our $1 million questions. No pressure.